Thank you to the Academy for the invitation. And I echo Sarah's comments and the discussions we've had as a panel that this is time, that it is the time for this discussion, and it is exciting and inspiring that this workshop with this design is happening. This question of what leads to reliable, sustainable delivery of evidence-based care in our system around the needs of people living with Alzheimer's disease and related dementias is so essential. And I'm going to talk about what we know and what by design we don't know that has to be learned into, and how that can lead to sustainable improvement. So if you go to the next slide, what we know is that the 4 M's, what matters, medication, mentation, mobility, that each of these elements of care is deeply evidence-based. And through the age-friendly health systems movement, we have learned that the 4 M's are a framework and a set that safely balances each of the 4 M's. So, for example, in mentation and the health of the mind, and particularly important for people with Alzheimer's disease and related dementias, Dr. Sheridan Yue has taught us that the safety built into the 4 M's related to delirium, that yes, we need to screen people for delirium, but we also know that that can lead to increased use of antipsychotics. So except in when we have the 4 M's as a set, that is keeping people safe because it is also ensuring that antipsychotics are not used to just manage the behavior of delirium. So again, the 4 M's as a set, keeping people safe from harm, and again, especially people with Alzheimer's disease and related dementias. Dr. Donna Fick, professor at Penn State, we know that including mentation in the set of the 4 M's starts to normalize the discussions around the health of the mind. Just as you said, Sarah, there's a lot of stigma around this, a lot of fear that providers have and clinicians have about talking about the health of the mind. And having the 4 M's as a set begins to destigmatize talking about the health of the brain, as Donna Fick has taught us, just as we would talk about the health of any other organ in our body, our heart and our lungs. So we know that the 4 M's represent the core set of health issues for older adults, for people with dementia and Alzheimer's disease, that it builds on strong evidence, that it simplifies care for providers, for care teams, and that, as I said, these different components of the 4 M's are synergistic and important to work together as a set. If we go onto the next slide, we also know that we can ask, on the next slide, we can ask people with Alzheimer's disease and related dementias what matters to you, and we can act on it, and we can organize care around the answers that people with Alzheimer's disease and related dementias and their caregivers, what they say to us. And here's a tool that can help do that. But we know that we can ask and organize the care around what matters. So we go to the next slide. We also know what measures will indicate that the evidence-based care is being practiced. These measures are process measures, they're outcome measures, they're access measures, and so we know and have this dashboard for the delivery of age-friendly care in the 4 M's. But if you go to the next slide, what we don't know is how the 4 M's should be practiced in each system, in each place that people with Alzheimer's disease and related dementias are showing up for care. We don't know that, and we don't know that because we don't know the culture of every site of care. We don't know the level of comfort of the care team, of the providers in talking about cognitive impairment, about dementia. We don't know what technologies they use. We don't know what's happening in the personal lives, the professional lives of the care teams. And we don't know which of the 4 M's they're already very strong in, or which of the 4 M's they'll have the greatest will behind them for change. But what we do know is that providing the tight expectation of the 4 M's as a framework and the measures that are expected on the outcome, we do know that if we leave a lot of space in the middle for sites of care, for care teams to learn how to adapt the 4Ms in a way that's right for their system, we do know that leaving that space can lead to sustainable change because it enables teams to make the choices that align with their system, with their organization, with their culture, with what matters to their care team. If we go to the next slide, we also know that the model for improvement is a mechanism, a tool through which systems can learn how they will adopt and adapt the 4Ms for the people in their community, for the workforce, for the people and caregivers. So here's an example. If you go to the next slide, of using the model for improvement for a team to learn its way into how do we ask what matters to people with Alzheimer's disease and related dementias, or anybody. How do we engage their caregiver in their conversations? And so if you start at the bottom, you can just see the different cycles that they went through of testing and trying and learning about the right way that worked for them about asking what matters. If you go to the next slide, what we don't know, again, is the impact of how we practice the 4Ms across race and ethnicity. So here's a sample of a look at health systems that were tracking the adoption of each of the 4Ms early in their age-friendly health system journey. They don't know, by looking at this, how the impact they're having by race and ethnicity. So what we do know, if you go to the next slide, is that if you look at your data stratified by race and ethnicity, we can learn how our adaptations of the 4Ms are impacting people across race and ethnicity, and therefore we can adjust and make changes to how we're providing that care, and we can close the gaps. So on the next slide, we also know that learning through this mechanism takes time. It needs to happen in small increments, but incredibly important so that we don't try an adaptation, 5 people with Alzheimer's disease or related dementias, and build something into our EHR and inadvertently build a process that increases disparities. But instead that we learn our way through these small tests of change that increase over time. We watch the data by race and ethnicity, and so that by the time we're ready to hardwire change into our system, we have a high degree of confidence on who it's impacting. And we also know on the next slide that having this level of autonomy, these tools to learn and build at the local level, brings joy to our workforce, and how important that is right now. And if you go to the next slide, we also know that we've reached over 1.4 million older adults with this evidence-based care using this approach. So thank you very much.